And there are a few other NCSLers that are on the line too. So
So we probably should connect. You and Jen and Bill and Nolan and I should connect after the meeting, after you've had an opportunity to talk with your colleagues.
yes,
Not-
definitely. I think.
Not today, I don't mean today. I mean,
Okay, yeah, that would definitely be helpful. I know that some
yeah,
of the other people that have been on the call, we've been messaging each other with some ideas and some things. So yes, happy to connect and chat to see what would be most helpful and what would work for the schedules coming up for the upcoming meetings.
okay, we'll email around.
It's how other states are defining affordability and accessibility.
Okay, well, good. That'll be the first thing we ask for. Okay. So Charlene, are we?
Yeah.
All right, so good afternoon. Welcome back. This is the Task Force on Affordable Accessible Healthcare. Representative Lippert and I, or Senator Lyons, are co-chairs, and we are very happy to have Mike Fisher, our Chief Healthcare Advocate, with us this afternoon. Mike, thank you for being here.
Good afternoon. Good to be here.
Do you want to share with us what it is that your office is
Sure.
doing? And
Yeah, I'm Mike Fisher. I'm the Chief Healthcare Advocate, a position that's defined in state statute. And before I came here prepared to talk about a project that we're in the middle of, and really to give you an update about it, a medical debt storytelling project. It really is very well timed for the conversation you are in for the purposes of this committee. But before I started, I guess I just wanted to make a high level comment. I've been a student of the challenge of how do you bring consumer voices to the legislative table appropriately for a long time. And there's no really good, easy answer to it. Public hearings are an answer. And so I guess I wanted to sort of recognize this moment and recognize the challenges that your committee has with 5 meetings defined, the limitations, the very clear limitations of that. And I think, it's part of my statute is to bring consumer voices forward. And that's what I'm doing here today. It's not a replacement for real live human people. But it is a step in the right direction, I think. So I think
We appreciate your being able to do that.
yeah. So I will go ahead and share my screen and get it on the right mode. I hope I've turned off all of the messaging services so that you don't see my advocates who are sitting in a hospital budget hearing at this moment and maybe chatting about it. I do have paper copies of this if anybody would like one.
I wouldn't mind having one. Why don't we all take one?
Yes,
But we
thank
do
you.
have it on our iPad. Write stuff down.
I want to introduce on Zoom is Meg Polite, who you all know as former chief of staff for Governor Ackerman, who is working with us on this project. And to the extent you have sort of specific questions about what's going on, I'll call on Meg and I may call on Meg to say a little bit about sort of her experience in getting to know this subject issue, because she has sort of fresh eyes. Here's my agenda for the day. Pretty straightforward. I want to, oh man. I want to stop sharing. Can you give me just a minute? I apologize. I have the wrong one pulled up.
I recognize that person on Zoom. Welcome, Meg. Good to see you.
Hi, everybody. Thank you for this hard work that you're doing. It's wonderful to be here on a screen. I wish I was there with you.
Next time.
All right, I'm gonna have to do it this way. All right, I need to get back to,
Is it something Charlene can help with?
I think I'm there.
Okay.
Oh. Share screen. Okay. Apologies. It's maybe not as good as it could have been, but it's what I got. So let me just recognize the pictures, the people on slide 2. I'm not alone. I have a whole team behind me, people who are working on, who are part of my team, who are answering, who are on the phone answering questions, and who are, and I also have to recognize as I look at this picture how outdated it is. We haven't been in person for a little while. A little shameless promotion. The HCA helpline is open. This is one of my advocates, Annalee. She is not in a cubicle in Burlington, in the north end of Burlington. She is at home at the moment, but working just the same. We're available, and people are reaching out to us today, like every day.
Are there people at the office in Burlington?
A few.
Yeah, there.
A few. So what do we know about medical debt data? Nationally, just last month, JAMA produced a new analysis that found that there was a $140 billion of unpaid medical bills that were at collection agencies. Here in Vermont, in 2019, the hospitals reported to the Green Mountain Care Board that there was $85 million of consumer bad debt that had been uncollected. The 2020 data, I do have the 2020 data. I didn't put it on here. It ticked down a touch, 81 million or something. 2020 data, you guys, when you're looking at what's going on in healthcare and probably everything, we're going to have to put a big asterisk next to 2020. As a percent of net patient revenue, it didn't tick down, but the actual number did. You talked a little bit about the Household Health Insurance Survey earlier today. In the 2018 survey, it found 40% of Vermonters who were had commercial plans were underinsured. The survey is indeed about, I believe it's about to be finalized and to go out into the field shortly. We engaged, as did others, in the actual questions being asked this year. I think that it's been improved. I think there will be some questions that will get at a lot of what you guys have talked about today. Important stuff. We have always gotten calls about medical debt, the helpline, and they fall broadly into two categories. Calls for which we can do something about. The examples are so technical. Somebody, a visit got coded wrong. Any number of problems that can happen along the way that leads to a medical bill. And so many of them we can do something about. Many of them we can't. Either because they're too old, past the period of time where we can intervene, or because everything was done according to the law, the rules. And yet someone's still desperate in front of us saying, I just can't pay this bill. The Medical Debt Storytelling Project is sort of runs along, it was inspired largely by what we saw at the helpline and what we've been hearing out in the field. But there's no overlap between Medical Debt Storytelling Project and our helpline work. We kept them at arm's length. The role that we play as an advocate for somebody and trying to help them solve their problems is really different than the role we're playing in collecting stories and presenting them to you. And it makes sense to us to just keep them separate. This is a non-representative survey. Really clear. Any data I give you about who called us and what percentage of them are this or that or the other thing is just a recognition of the people who self-identified and called us. And we did take a lot of information about age and insurance status and race and income, and residence and more. So we will be able to tell you something about who we're talking about. Welcome, Senator.
Thank you for saying that. You beat me to it. Welcome, Senator. But we understand. We understand. Red did not help.
It's a healthcare issue.
Sorry.
That's okay, I interrupted. I looked at the number just now. I think we're up to 1,930 or some people have participated. Yes, Senator?
Does someone have to speak English to take the survey?
No, we do invite people we gave a phone number, we gave various ways so that we could respond to.
Did you get any survey responses in other languages?
Meg, were you able to hear that question? I don't believe so.
I did hear the question. We did not get other responses specifically in other languages, but we definitely got responses from non-English speakers. I'm not sure if you'll see some examples in what Mike's going to present to you, but very clearly when people identified from other races and countries, you could tell their English in their own words they were struggling with the words to answer the questions.
Okay, so verbal interview where if there was limited English proficiency.
Exactly.
Okay.
And in addition, we did a little bit of a targeted outreach to try and make sure we had as diverse as we could group of people who at least knew about the survey. A surprising number of people, I just want to sort of recognize, we were blown away here. We knew we were going to hear some horror stories and we knew we were going to hear some passionate stories. But I had no idea, and I thought we'd get a couple dozen that we could sort of tell you, here's what people are saying out there. To have almost 2,000 people respond. And certainly some people filled out the survey and gave us very little information, but many people spent a lot of time and really told us in their own words what's going on. And that's sort of the most important part of this. It is that is an opportunity to advance people's voices so that let me just say there's two main goals that motivated us here. One, and I'm not sure exactly what the order is as I sit here right now. One of them is certainly to make sure policymakers know about this and to try and affect changes that will reduce medical debt. And the other one is people live in isolation about this issue, embarrassed, feeling horrible about the dynamic. And we really wanted to do what we could to reduce the stigma. I think people feel a sense of individual blame about something that I would assert is a structural problem. It's not people's fault that they got sick. That's what we're talking about here. People got sick or had an accident, didn't have a Cadillac plan, afford a Cadillac plan, and therefore have medical debt. And I really want to send as clear a message. And we have some work to do. I'm going to ask your advice a little bit about how to do some of this. Really getting the word out, saying to people, hey, you're not alone, and this is not your fault. This is really a
That
structural
does
problem.
raise a question about how you publicize the survey in the first place.
Mhm.
And then, so the next step will be letting people know some of the concerns that you have about reducing stigma and
Yeah.
blame reduction.
Yeah.
How did you get the survey out to folks?
So we did, and Meg, jump in where I'd miss, we did press releases everywhere we could. We approached every group we could think of that could get it out to their members. We did a paid ad on Front Porch Forum, almost statewide.
And we reached out to all of you legislators as well, and many of you shared it on social media, in email newsletters, and on Front Porch Forum yourself directly to your constituents.
A relatively high number of people said that we could share their stories. That also surprised me. I expected a lot of people to say, I'll tell you, but I don't really want you to tell the details of my life. And 87%, we have a lot. We have a tremendous amount of work to do to get through this. I think I'm ahead of my slides. To get through this and to develop the themes and to be able to make a summary and a report about it. This is just a slide to say it's still open through the end of the month, so people can participate still.
The end of August.
Yes, thank you, through the end of August. And this is, I started to say this already, we have a great deal of work to do. I mean, for instance, the race field, we decided it made most sense to let it be a text field, not give people boxes they had to check off. So we now have the work of going through and defining that in a way that makes sense.
That's interesting, because my question was going to be, I mean, this is, obviously very compelling. It's all qualitative. It's really hard to say we had a goal of getting 10% BIPOC participation in the survey, because you have no idea, and then making sure that you're properly categorizing people so you know if there's a disparity.
Well, yes, you're right. There's two things I want to say. One of them is we understood that even if we had X% of the people who filled out the survey were BIPOC, that we wouldn't be able to extrapolate from there about the experience of BIPOC people in Vermont versus white people in Vermont. So that's one part of the answer.
You still might set a goal to say, we want to make sure this voices, we're understanding the unique stories from these voices.
Yeah, I think you're right. I think what we'll be able to do is report to you how much participation we had. Yeah. Meg, do you have anything to add on that point?
I would just say you're correct. We knew from the get-go that we weren't trying to get a representative story. We were trying to get stories to show the picture. We did reach out to, and this was shared by both of the NAACP chapters as well as Migrant Justice, to their members and rural Vermont, all touching some of the BIPOC groups in Vermont, but there's so much more. And I think the language issue is huge, and we just knew we didn't have the resources in this project to do a survey that would take all of that into account, which would really have to be going out and reaching all people and asking them about their experience to put this into a category. But I can tell you for sure that in that race ethnicity field, there's a wide variety of how people have self-identified themselves, from different countries to different regions to colors. So there's definitely stuff in there, and we will be able to pull out at least what percentage we heard from using this tool, which was really primarily an online tool. So we offered people print, we offered people verbal, but most of the ways we were advertising it was through some form of online engagement. So we know we missed huge swaths of people.
Yeah. And then I'll also remind you that the Household Health Insurance Survey is a representative survey. It's a high quality survey, and it does have, I believe, though I haven't seen the final draft, I believe it will have medical debt question in it. And that may give a little bit more of an ability to understand how, how does medical debt, how people across different groups in Vermont experience medical debt.
Well, when you do an initial qualitative analysis, then it does help you identify places that are unclear
Mhm.
or where the gaps are. So that could direct you in the future, but it could also direct you, as you said, to other surveys that are going on and
Yep.
where those gaps might be filled in.
We've only gone through 400 surveys so far, a little bit in preparation for today's meeting. Again, we have close to 2,000 to do. And we generally see them in these categories that I've listed here: access to healthcare, affordability, impact on daily life, surprise, and collections. And I want to also recognize my bias here. I and others are interested in the impacts of medical debt on people's ability to heat their homes or put gas in the car. That's really important. I'm most interested here in the impacts of medical debt on people's ability to get the care they need. So that's sort of the main question that I was really curious about. Again, I'll use that number, $85 million in medical debt in 2019. What does that mean? I'm sorry, $85 million that hospitals reported in 2019. Hospitals are about 40% of the healthcare system. So, and I don't think it would be correct to just multiply out to, to the other parts of the healthcare system, but medical debt is, but anyway, I'm trying to get it to boil this down into real human stories.
Well, but when you do that, it also helps us to define affordability.
Yeah.
Because if people can't afford to heat their homes or feed their families, there's the cutoff.
Yeah, I think, Senator, we talk a lot in healthcare reform about the right care at the right time.
Mhm.
And I think the question, I think I know what happens to people when they owe their hospital or their provider, $5,000 or $10,000 or a high percentage of their income when they need to go to the doctor. I think I know what happens to people, but I really wanted to hear it in people's own words.
Wrapped up in that, a lot of these stories are about people foregoing care because someone else in their family needs it more. So is that in the same vein for you?
It is, and it's an interesting, thank you for saying that. It wasn't exactly on my mind when we asked the question, that it wasn't just, of course, your own experience. It is people within your economic unit. If your husband is experienced, has a lot of medical debt, it impacts you or your kids. We wanted to put some real words in front of you, and wanted to demonstrate the statewide-ness of this. And so we just picked one quote from each county. And I'm just going to go ahead and make a decision. I'm going to read. Addison County. My wife has epilepsy And she prays every night she doesn't have a seizure because my insurance would not cover any of the costs. It was from a male 18 to 26 insured. From Bennington. The premium for my health insurance is manageable, but the deductible is not. I'm in chronic pain, but have to pay out of pocket for the care I need. Female, 41 to 64 insured. Caledonia. For years, I went to doctors, dentists, etc. for major emergencies only because lack of affordable insurance also would skip on necessary prescriptions for the same reasons. Female, uninsured.
Are you saying a percentage of females as compared with males, or is it pretty equal? You don't know yet.
I don't think we know that yet. It's an interesting question.
Yeah.
Chittenden. I'm postponing medical treatments because I'm in the deductible period and cannot afford to use my private health insurance. Essex. My income is Social Security, so I can barely afford Medicare Part B. Supplemental insurance and Part D, which now cost me $320 a month. Monthly medications are approximately $1,000 my cost. And I was in the proverbial donut hole in May. Franklin. Husband owed $50 to primary care physician that he couldn't pay. Would not go see him about his GI issues because he felt bad and worried they wouldn't see him with a past due balance. Grand Isle. I have suffered pain in my feet so that I am forced to be less active, causing my health to suffer further. Simply cannot afford these high medical bills, even with the insurance deduction. Lamoille. I have several serious conditions, but try not to go to the doctor because it's too expensive to see all the specialists I need. My husband had 2 emergencies last year that were more urgent, so I try to go without care. Orange. Today, every decision is looked at with an eye to the financial consequences, not to quality of life or even length of life. Orleans. Living paycheck to paycheck, I didn't have an extra month worth of rent and utilities to pay for the medical bill. I avoided going to a primary care physician. Rutland. I put off going to the doctors for as long as I can, hoping things improve on their own. I was supposed to go to a surgeon to discuss diverticulitis, but have put it off for at least 6 months, knowing I do not have any extra funds for the appointment or surgery. Washington. I can't acquire more medical debt and put off basic debt tests until affordable and sure of coverage. And Wyndham. My son's type 1 diabetes care is so expensive, myself and my other son can't afford to go to the doctor. And Windsor. I constantly put off care. I have insurance, but never know what my obligations will be. Once you enter the medical system, it's a black hole of expense.
Gary,
I guess I want to just pause for a second and recognize, I just want to pause for a second. Let it sink in for all of us. Um, So I live in this world of talking to people about their challenges of access to care every day. And I hear the, I'll say, secondary trauma that my advocates experience as they attempt to help people. So there was, as I've paged through the responses, I can't tell you that there's anything I've heard that individually was all that shocking or surprising or I hadn't heard before. But there is something immense about the sheer volume here. We touched a nerve. And Meg, maybe I'll ask you to say a sentence or two about, Meg has done more than anybody of actually reading what's come in. So I'd welcome a sentence or two from you, Meg, about your experience with it.
Yeah, well, I think, thank you for letting me speak for a second, and hello to everybody in the room. I think you all know that I've also been involved in the world of medical healthcare, medical coverage, and these issues for a long time, but I was in no way prepared for what I took on in offering to gather and go through this information. And I think I'll just say three things have really, really struck me from this. One, it is so hard to read the volume of what we've received. It from, as Mike said, I've only gone through 400 surveys before so far. It seems like about 30% of them are telling a story from what I'm looking at. So that's a lot of information where people are telling their personal trials and challenges. The second is I was shocked by how many people are foregoing other necessities because of it. Like, I would say every single survey, we had a choice where people could check things that they've had to forego to pay for their medical debt. And the list was, relatively long, from things like electricity, heat, childcare, transportation. I think there are about 12 things on the list. I would say every single survey has one or two of those checked, and some have 6 to 8 of them checked. And the third thing was how accepting people seem to be of this debt, and that they're very willing to pay it. They automatic, there's things that people say like, I know I had to pay my bill even if it made it harder for my kids to have something to eat. Like the something in our society and something about the fact that people know they got treated and they're grateful for the care they're getting makes them they want to do what's right. They don't want to walk out on it, but they're strapped in that they just don't have the resources. So it's going to take a while to go through all the other ones and find the pieces, but I'm anticipating that at the end, you would see quotes like we just saw, hundreds of them, maybe 500, 600, 700 quotes like what we just saw, just to give you an idea of the volume that we're seeing and how concise and articulate people are sharing their story and problem.
So as you're looking through all of the information that you have, are you able to get some specificity around socioeconomic status for any of the folks, income levels, that kind of information that would tell us a little bit more about the relationship between the insurance premium or the hospital charge and then what people are actually capable of supporting?
So we did collect income, self-reported income information. So we will be able to break it down in that way.
Good.
And we did collect insurance status. So we'll be able to break it down in that way as well.
Terrific.
Yeah, I would just say once the survey closes and we put it in a database, because right now I'm literally just going through surveys, so I can't sort on all the different criteria. But as Mike said, we collected a lot, so we will be able to look. We also had an open-ended field on the amount of debt that people have, and it ranges from, you know, people who put something like $127.32 in to people that put more than 50,000. So that field we need to go through and add up, but we will be able to get a self-reported total of what people are saying. And then again, because we sorted on county, we had county reporting, we could take it down to the county level and break out, you know, debt per county or income levels per county. We can break it by gender, including that was self-identified, so people could be trans female, trans male, non-binary, and as well as male and female. So there's a lot of ways that once it's in the database, we'll be able to extract and pull clearer pictures of what that looks like out. But right now I'm just looking through them, the 400 I've gone through and grabbing the quotes out.
Thank you.
Can I say that one of the things that I'm struck by as well, and I keep sitting here thinking, I think I understand this correctly, but these are folks who don't have access to Medicaid. So, because if you were on Medicaid, theoretically, you
Right.
wouldn't have this medical debt. But you could be at that point of socioeconomic status where you might have been on Medicaid at one point and no longer on Medicaid, or you might be eligible for Medicaid at another point in time. But that there's a whole, because we have a high percentage of Vermonters who actually access their healthcare through Medicaid, Vermont Medicaid.
Right.
That's a whole world of people who could be very well in this same situation or worse, or as bad, if it weren't for what we provide through Medicaid.
Yeah.
But for Medicaid, and we're in a Medicaid expansion state. And you're thinking, you know, think about Vermont. That's well over 100,000 Vermonters,
right,
who are not in this survey because this is not to say that's doing such a good job, but just to think how much greater
Yeah.
the potential is for people to be suffering from medical debt.
Exactly.
Yeah, I think the thought that comes up for me in response is this question of sort of what drives behaviors here. And, you know, when, you know, we asked the question a little bit broader about sort of medical debt in your sphere, you know, like if you grew up in a family where your family was fighting medical debt, you know, like your parents were struggling with medical debt their entire lives, how does that, you know, does it impact your thinking? We want people to get care, right? That's the goal here. You know, we frame it in terms of preventative care to you know, getting to your primary care doc so that you better outcomes and don't cost the system more. But so sort of how does the legacy of medical debt, people's families impact them? And I think that's the one caveat I would come up. You know, I think people who are on Medicaid, some of that, people are not exactly rational thinkers. I'm going to go to the example of how many people have switched to a Vermont Health Connect plan that has much higher subsidies. You know, we have a hard time getting people to do things that are in their own economic interest sometimes. So I think it's a backdrop in a lot of people's minds that is a wind that pushes in exactly the opposite direction of what we're all trying to do in healthcare reform.
I have a quick question. On the insurance question, are you just asking insured, uninsured, or are you asking to make the insurance?
We asked what type of insurance.
We'll get pretty granular data on that.
And I was remind us, it's all self-reported. I think sometimes policymakers have a hard time distinguishing between Medicaid and Medicare. I think people do as well.
A lot of people talk about chronic pain and kind of chronic issues. And I recall from talking to the chief medical examiner in West Virginia when I was there looking at the opioid crisis and overdose death rate. He said, you know, so much of what we've tried to do with opioids is treat pain, but what really people are trying to treat is suffering.
Mm.
And if they can't get a knee replacement, they can't fix their teeth, they can't get care that is for a chronic issue, they would likely turn to opioids to manage the suffering instead of pain. And it just strikes me how much suffering we see here that isn't like I can go to the doctor and, you know, get surgery. A lot of it is I'm gonna be in chronic pain for the rest of my life. I don't know what to do. I can't manage that. I don't know the way to sort of get more detail about those stories and what people do to cope and how expensive that can end up being for all of us.
Yeah, thanks for that. I would just add to what you just said, dental. Many of the stories of chronic pain are dental stories. And many of the access to care challenges are dental stories. But you also said something about getting a more, a richer, you didn't use the word, but a more detailed story. And it's something that we have entertained, whether we could go a little bit deeper with a smaller set of people to get a more full story. And we're still figuring that out exactly.
Right.
I also want to recognize, at some point, Chairman Lippert asked me across the table 2 years ago or something, how does the healthcare advocate decide what the healthcare advocate focuses on? And I have an answer that was something like, well, we have the information that comes in through the helpline, that's primary. And, I've got a great team, and we sit on every board and commission that you guys dream up, or I have dreamed up in past years. And
You dream up an estimate.
and we read a lot and we look at what other states are doing. But there's something, this is a new way for us to interact with Vermonters. This doesn't demonstrate it a little bit, nobody ever calls the healthcare advocate's office and says, I went to the doctor and I got treated and my insurance company worked exactly according to plan. We're never going to hear those stories. And those stories are clearly out there. But this is an experiment, one I hope to do much more of picking areas of healthcare where not just waiting for people to call us, but we need to reach out and hear more directly. And I have to say, it's been on my mind, and I really need to figure out who to partner with to really hear firsthand stories of race disparities, right? How people are treated, BIPAC people are treated when they get care.
It's really interesting because so many medical clinics and hospitals now are doing patient satisfaction surveys. And I would think that insurance companies might be doing that as well.
Yeah.
I don't know if there's any way to access that information. Some of it's good and some of it's bad.
Yeah.
Overall.
Well, to the race, is there race data in those surveys? Is a question that's always been on my mind, and one that I have asked and never got a really good answer about.
So what is the timing on this? So obviously, I think this does inform our work. It would be helpful to see some of the analysis that you folks are doing and what comes of it. But
so the survey closes at the end of this month of August, and we will work to pull together summaries and presentations about it, takeaways for you for the legislative session.
will it be in time to come back with a report to us? Before, would you have that analysis done, say, by November or December?
I will have something to you whenever you ask for it. My depth of analysis will be more. Just to give you a little insight into sort of my life, I've just climbed out of the hole that is, maybe I should say the ring that is insurance rate review. And my team has been up to our eyeballs in that. We're not even done.
Oh, wow.
A decision has been made, but there's still motions floating around, and so that's still happening. And as I referenced, this week and next week is hospital budgets. And that's a tremendous effort for my team and also of tremendous importance when we're talking about the cost of our system. I wonder if I could spend just a minute responding to a few things that have been said this morning. A few thoughts that are on my mind that I wanted to Chairman Lippert mentioned a few things that other states have done, and I want to agree with him on those and add, I think Colorado has done some very interesting.
Can I be clear? I was not trying to list all the interesting things that I
Well,
think we
there's
should
lots
learn.
of
from.
things.
Please. feel free
Oregon,
to add.
Colorado,
Yeah.
Maryland.
And I think, I'm not sure whether Representative Donahue was exactly going here, but the Medicare Savings Program eligibility is a place where the state has some options. Maine has done something interesting that I think we should at least bust out. I want to be clear, these are nibbling around the edge of things. This is in the realm of things that I think are, well, Colorado might be a bigger step, but things that I think are reasonable, certainly reasonable to entertain. I would phrase the New Mexico story a little bit differently. I think it's a New Mexico style way of raising money and applying that money to improve access. They did something a little bit broader than just waive mental health copays for fully insured people. That I think is worth looking at. I want to remind us all, we have something like $500 million of ARPA monies that have not yet been allocated or identified where they're going to be spent. And I know there's a tremendous amount of need everywhere, and I sure hope that at least some of that goes directly to consumer access to care. And would have proposals to put on the table about that. I want to recognize, I'm not sure I've ever heard it said at a legislative hearing. I understand why there's a tremendous amount of effort that's put into, attention that's put into people who sit in emergency departments for mental health conditions. There is another, I'm not sure if it's equal or smaller, or there's another tremendous issue playing out in our hospitals today. And that's people in hospitals who are subacute, maybe even in custodial level needing of care, who are awaiting skilled nursing facility placement for which there are none. For somebody who has a behavioral, who's been violent, or somebody who has a drug addiction issue, you just can't place them. And those people sit in hospital rooms, spending a lot of money. And it's sort of similar to the mental health one. It's a structural problem. You know, do we need places that are designed to take the pressure off of hospitals? UVM told us the other day that there were something like 30 or 40 people on that day
That's right.
in beds.
And the workforce issue plays a huge role in what
Across
you're
all of
talking
them.
about.
And then because long-term care was mentioned.
Yeah.
A Washington style, long-term care funding. Washington state style is something that is maybe a little bit outside of the health frame of this committee, but I can't help but mention it because I think it's really cool when I see states stepping up and doing some really innovative things. And then I can't help but mention, there are also bills on the committee, on the healthcare committee that, you know, particularly focus on how much hospitals, uncompensated care really belong in the bad debt category and how much of it really should reasonably be put in the free care category. I'm not talking about increasing the amount of money that hospitals don't collect from people. I would like to reduce that. But we see plenty of evidence across the hospital system where there's, where people who are economically eligible or low enough income to qualify for their care policies, but who are roped out of those systems using things like durational residency requirements or hospital level residency requirements, or other ones that frankly we worry have a race equity concern.
Go ahead, Senator.
So I apologize for being late. Maybe some of this was said. I think this is a good start, but what I don't really get is what the picture is of the people that are in this category. Is it mostly working poor?
Would you mind speaking into the mic 'cause with your mask on, it's hard to hear. Thank you.
I'm trying to figure out what this population looks like.
Mm.
Because as you throw out solutions to that, what I'm shooting at for a group of people, what those solutions might be would be different in each of this. Is this working poor? Are these people that have some insurance and it's high deductible and that breakdown in that would help me through figuring out what I'm talking about. And will there, as you go further in this survey, will this be broken down further so I get a better picture of what the categories of people are in this?
Yes. We certainly will be able to give some more insight about the people who filled out the survey, how many, what percentage of them or what percentage of the debt was for people who are uninsured versus insured with a high deductible.
Mhm.
I'm not sure that.
And will I find out how many are working and not working? Because my sense is this is all pretty much adult population that is, and it sounds like working poor to me.
Yeah, and by income. So I think, I'm not exactly sure. So I think you can extrapolate from that working poor. But we did not ask a question about employment. We did ask about income. And we did it in income ranges. We have sort of buckets that people place themselves in.
That picture would be helpful to me. And I'll anecdotally say, I've had 3 employers come up to me in the last week that are one that owns a small bakery. And they feel lost to be able, and they want to help employees, but they don't, our information is kind of all over the place. And there's nobody for them to really sit down with and have a talk with for them to help.
I want to echo exactly. The last thing you said is a really important point and one that troubles me. I'm a consumer advocate. My office is a consumer advocate's office. We're not a small business people's advocate, and we get calls from people who are saying, I'm trying to sort this out, and we help. Sometimes I help them to take it out of the realm of the advocates, but the role is a bit different, and it troubles me greatly that the people that are available to give advice to those people often are trying to sell them something. Not saying they're not giving great advice and getting great options. I'm just saying that there isn't a counterpart to me that gives small businesses best advice they can about their employee benefit options.
Should there be?
Without there being sales.
Yeah.
Pitch involved.
Yeah.
Well, if you're trying to compare between that world and you're running a bakery, which was the people that I sent, and they've got 8 employees, and I want to do something to help.
Yeah.
I call Nolan. Nolan gave me a bunch of links, and I sent out the links, but there's nobody really just to sit down and talk to them.
And it's a really tricky calculation.
Mhm.
Hey, one other odd and end that I recognized is to clarify that the current open enrollment period goes through October 1st. The ARPA open enrollment period.
Can we be very explicit about it? I think it's very important for us to make that very clear as much as we can, that this is the open enrollment period for accessing the additional federal assistance, which was scheduled to close on August 15th, and for which Vermonters can access enormous help if they're eligible with premium assistance with federal dollars. And
Yeah.
that it's been extended to October 1st. This is very important information for us to get out into the public realm. Again, I referenced some federal data that I'm asking, and I'm hoping we'll talk planning, have Eva come in at our next meeting and talk to us about it. But this is, I think it's just so much more important that
Well, it would be nice to know what, if any, publicity is happening around that, because I think we haven't seen enough of it. And as,
So
maybe New York State has a,
we see, I see ads on television from New York
Information
State.
out.
Yeah, but
Vermont hasn't. got it.
So let me clarify that the ARPA subsidies will be in place for the next year. And so people who are signing up for next year's health insurance will be eligible for it. If you're direct to your insurance carrier this month, today's the 19th.
Not much time left.
I was going to if 3 days ago, by the 15th,
Right.
you had called to switch to direct care, you would have been eligible for next month's ARPA subsidy. If you didn't, you'll lose it. You just lose it. You lost what could be $1,000, $1,200 a month for a family.
Right.
And so it's substantial subsidies that I am very afraid many Vermonters are not taking advantage of. And I'll be clear that it's people who are direct to carrier. And I also want to be clear that the subsidies, since we're talking about out-of-pocket costs, the subsidies available to people who have had any unemployment last year, even a week of unemployment, is incredibly generous, and it covers cost-sharing subsidies as well. And so I'm just guessing that we are going to be at the end of this looking back and shaking our heads at how many people missed those federal dollars.
Can I just clarify too? So if you are direct with the insurance carrier and you make a phone call to switch to direct Vermont Healthcare, you can switch your plan exactly as it is.
Yes.
You're not having to make any other decisions other than saying, I want to move what I currently have over here so I can get my subsidy.
Yeah,
Is that correct?
almost.
Okay. Pretty close.
But close enough. I mean, there's the one little detail of overloading, but that's detail
But
that,
it's an
Yep.
easy process for consumers to take, to
Yeah.
pick up the phone and say, I want to move over here. to
Yeah.
be able to get my subsidy.
So I mean, I just want to know, because I got there was a terrific one sheet or two sheet piece that Legal Aid sent out that included this with a whole list of don't miss out on all these important things, which I converted into, put it on our local front porch forum. But this piece was only one on a list of 10. And so I do think it's important for a separate highlighting just of this.
yeah, in a couple of weeks ago, in insurance rate review process, we understood that 10% of direct enrollees had moved. And look, some people, the subsidy goes really high. I mean, the subsidy goes
Yeah.
as high as it can, but with the point where it crosses the cost of the actual plan is high 600% of federal poverty level. It's very high. And I understand some people may look at it and say, I would save $7.50. It's not worth my trouble. But for other people, we're literally talking about over $1,000 a month. And, all the jumping up and down and excitement about the stimulus checks that went out, we're talking about that much a month
I
for some
think
families.
if there's a single thing that we can do immediately, it's to make sure that all Vermonters who are eligible access this right now, especially with us feeling badly that we were meeting after the deadline of August 15th, but if the
The
extension is.
deadline is until October
But
1st,
yes,
right?
but I'm just saying that, so the extent, it's been extended to October 1st.
Yep.
And I think we should have something that goes out to all of our colleagues
Yes.
to highlight this with something that's already prepared to use on social media, front porch forum, et cetera, that they don't need to modify. Because I think that would be something immediate that is in fact hugely impactful for Vermonters and our constituents.
No, well, one of the, was it 2 years ago? I mean, our committee really dug hard to try to find a way to help this exact group of people who were on that cliff,
Yeah,
who fell off a cliff and couldn't come up with something. And here it is, handed to us
In front of
on a
us.
silver platter.
can you send us the information that you sent out to Front Porch Forum, and then
Yep.
We can send it out to our colleagues in the House and the Senate.
Yep. Yep.
And because I do think that is something that we can do right away, and it will save Vermonters money overall in the short term.
And I will say the TiVo website has.
Right,
People
right.
can get there too.
exactly.
Links in the book.
Yeah. So thank you
Thank you.
for the time, and thank you for allowing me to chat a little bit, and thank you for taking a little time to honor the stories that I was able to bring forward today. And I'm looking forward to, and I'm open to your suggestions, each of you right here, to ideas of how to share this kind of data, this kind of stories in a way that honors them and also and doesn't overwhelm lawmakers, or maybe it's supposed to overwhelm lawmakers, but I'd be happy to talk more, and thank you.
Well, thank you. And I think any analysis that you do have and that might inform the work that we're doing, by November, would be extremely helpful. Have you come back in, as you and Meg maybe consolidate some of the work that you've
I
done.
think Meg is with us for just a short while. Did Meg leave? And then Meg is moving on to a new position. Meg, you want to announce your new position?
Uh-oh.
Some of them saw that I'm going to be working with you on Alzheimer's related issues as their new policy director, but I will be here to help Mike through the middle of September, start to get this in place and obviously support afterwards with questions, since I was part of the initial collectors. And I would just say, as you're really thinking about what you're hoping for from this data, what you think you need from this data, we can provide some of the specific breakdowns that you asked for, but the highest value that I see from the data are these personal stories, because all the other fields were self-reported. So sometimes they would check like, I don't have insurance, and then it would say, what's your insurance plan? And they would say, I'm on my employer plan. So there were the other fields are because it's self-reporting, it's not a sample size that's been divvied out correctly. The most valuable information is from the stories. And if there's things you want to hear, like I believe it was Senator Rahm, I can't tell because your picture's small, but that asked about like one person putting off care because another person is getting care. Like, if we know those things, it just happened that there were 2 stories like that in the examples today, because those were stories that had come up. But those are the kinds of things that we can be looking for as we're going through, so we can provide some numbers on those specific details. If you want to see, are you finding in a story a connection about, for instance, another one I see a lot is high deductible and the high cost of insurance. How does that compound together to make a problem? Then we could flag those and we could start getting more quantitative data around those issues. But the simple breakouts around insurance and employer even income levels, because people are reporting for their whole family, and one person in what they consider their family may be on an employer plan, and another, they may not be married, and another person may be on Medicaid. So it's cloudy the way the survey is. So really think about, what do you want to see from the stories, so that we can be looking for that and flagging that, to then come up with the data of, okay, we saw this many stories around this. So that's where it really, to me, is the richest.
Thank you and congratulations. I'm sure we'll be seeing you.
I'm looking forward to that. That's one of the perks, is getting to work with all of you again.
All right, terrific.
I just have a couple more comments. So one, you know, when I read something like, my wife prays she doesn't have seizures because my insurance wouldn't cover any of the costs. I mean, I see a path to do something about that. I could be wrong because I'm not on the healthcare committee, but that seems horrible. You know, and I know you were saying you can only really get involved if things are illegal, or, you know, they're kind of really outside of the realm of what should be people's experiences. But I mean, a list of things like that, you know, where there's a pretty specific policy change, I think would be really helpful. You know, and then looking at things like someone said, for years, I couldn't do this. It's also, I think, helpful for us to know what has changed for people, what does work, you know, when I know that probably in healthcare community, we talk a lot about when things finally work for someone, they have better insurance tied to a different employer, they, you know, they have better income. But, you know, you said, like, we'll never know when things are working right for people, but, you know, we also want to know when things are working for people, when they might have gotten out of a bad situation because they made the right phone call. I mean, so much of what I hear from healthcare is, I needed to know the right person to talk to get like a magical change made in my life, you know. And that's the scary thing, is that it's so uneven for people depending on who they talk to and, you know, where they look for help. And I feel like it's really informative for us to know when someone had a positive deviance because they knew where to get help.
Yeah, it reminds me something that I wanted to say, and I was just saying about you, and now just one more thing in response. I think healthcare, more than other policy areas, beware the average. You know, you know, the average cost of housing, it's a range of the cost of housings. You know, obviously Jeff Bezos pays more for his monthly costs than, you know, the average person. But, you know, other than that, you know, housing has a certain range. You know, I don't know what the average healthcare spend in Vermont is, something like $1,000. You know, if you just divide the total cost by the number of people, you know, to a lot of people, $10,000. I was like, that's crazy. I never go to the doctor. And then to a small set of people, you know, they're millions.
That's crazy. I spend a lot more than that, right? Exactly.
But the real point is that the details that go into people's lives that drive the cost include many factors that you just can't average. And so I think whenever I hear people give averages in healthcare, I time out. Wait, whoa. This doesn't exactly work this way as it really plays out on the ground. There's a bazillion details behind each of these stories that it's impossible for us to really evaluate. On the face of it, seizure care should be covered. I don't know whether that person is high deductible. I don't know whether that person has an employer-sponsored plan that's very limited. A lot I don't know. So.
Thank
you. I hope people receive some kind of response, not a personalized response, but something like, this is what we heard, this is what we're able to do with it. You know, these are solutions that we can advance right now. I think people deserve some feedback when they share such a personal story.
Well, that's what we're about to do, hopefully.
Well, yes, it is we really do need to reach out to the people who participated and gave us their emails, many of whom did.
Okay, we're good.
Okay, thank you.
Thank you.
So I need to share a breaking news report on workforce and healthcare access. I just got a phone message from Central Vermont Medical Center. They have to postpone my mammogram scheduled for tomorrow because of a staffing coverage issue.
There you
So
go.
there we go.
It affects everyone. Wow. Charlene, is Jen Kirby on? She is on Zoom. Jen, are you on Zoom? There she is.
I'm here.
Well, I thought that we will, we should move into a review of the Act 48 principles. And then we'll have a discussion about future meetings.
Sure. Do you want me to share my screen and put up kind of that presentation that
Either,
no one
either,
had copies made of?
either document is fine. We have the
think it's-
short version and we have the PowerPoint. So
I think the PowerPoint one may be easier to look at as
it's
put
easier
together.
to-
It's a PowerPoint.
So let me just. Charlene, can you let me share my screen?
No.
Thank you.
one for Richie.
Okay, can you see my screen?
extra one.
Can you all see the document?
Yes.
Yes, we can.
Great. And just again, I'm Jennifer Carby from Legislative Council. This was a presentation I'd put together a couple of years ago when the issue of the Act 48 principles came up in the House Healthcare Committee, and it just seemed like an easy way to look at them. So it starts off by quoting from Act 48, and just to note that the principles are also codified in statute. That's actually the one pager handout that I gave you that also has the principles on it are the ones in 18 VSA section 9371, which is the first section of the Green Mountain Care Board chapter. And there have been some amendments to the principles since they were initially enacted in 2011. So these should include those updates. So Act 48 starts with, that says the General Assembly adopts the following principles as a framework for reforming healthcare in Vermont. And the first one says that the state of Vermont must ensure universal access to and coverage for high quality, medically necessary health services for all Vermonters. Systemic barriers such as cost must not prevent people from accessing necessary health care. All Vermonters must receive affordable and appropriate health care at the appropriate time in the appropriate setting. So this sort of picks up on some of those issues that Mike Fisher just highlighted for you in his presentation, I think. So as far as assessing where you are in achieving these. Let me know if you want to stop on any of them. Otherwise, I will just go through them. Principle number 2 says that overall healthcare costs must be contained and growth in healthcare spending in Vermont must balance the healthcare needs of the population with the ability to pay for such care. The third principle says that the healthcare system must be transparent in design, efficient in operation, and accountable to the people it serves. And the state must ensure public participation in the design, implementation, evaluation, and accountability mechanisms of the healthcare system. Principle number 4, primary care must be preserved and enhanced so that Vermonters have care available to them, preferably within their own communities. The healthcare system must ensure that Vermonters have access to appropriate mental health care that meets the Institute of Medicine's triple aims of quality, access, and affordability, and that is equivalent to other components of healthcare as part of an integrated holistic system of care. And just to note that the Institute of Medicine reference was actually not accurate. That's been changed in legislation since then. So the hard copy, the one pager that I gave you has slightly different language there. Other aspects of Vermont's healthcare infrastructure, including the educational and research missions of the state's academic medical center and other post-secondary educational institutions, the nonprofit missions of the community hospitals, and the critical access designation of rural hospitals, must be supported in such a way that all Vermonters, including those in rural areas, have access to necessary health services and that these health services are sustainable. The fifth principle is that every Vermonter should be able to choose his or her healthcare providers. Number 6, Vermonters should be aware of the costs of the healthcare services they receive.
Just
Yes,
hold on, then there's a question. Go ahead.
I mean, could just be me, but I don't find it that helpful to just read these without like stopping to say, are we measuring them? Like, what are we doing right now? Are we just reading these?
Let's go through them
Okay.
first, and then we'll come back to that.
Okay.
That's a longer conversation, but, you know, yeah, much longer. But for example, we do have provisions that allow people to pick their provider. But we'll come back to that question unless somebody has a specific statement to make. Go ahead, Jen.
okay. So number 6 is Vermonters should be aware of the costs of the health services they receive, and costs should be transparent and easy to understand.
So just as an aside, to answer Senator Hinsdale's question, the transparency issue, passed legislation last session on increasing hospital cost transparency, and that is still being worked on. Also, insurance company transparency to demonstrate the costs of services and then the payment for services.
So we don't measure if Vermonters think the costs are transparent and easy to understand.
We don't measure what Vermonters think.
We don't know if it's easy to understand unless we ask
Well, the
people.
only way we can know if it's easy, right, is to look at it and determine, do we have a comparative analysis of all the hospitals for a colonoscopy, for example? So then you start to get into more specific details. And in some cases, we meet the criteria, and other cases, we do not meet the criteria. But so it gets to be more complicated than that.
But there's no formal process
Right, there's no.
that anyone who goes back to this and
Okay,
has measured it.
okay.
There's
No.
no formal.
My government accountability committee
Right,
brain is like, what is
Well,
happening?
yeah,
There's
there's-
no desire, what are we doing?
Well, but I have a general question, but I'll wait till the end.
Okay.
Because I think it's important, because Act 48 gets brought up in
Right.
many
Right.
contexts and for many purposes. And I think it's important for us to understand, and maybe Jen can help us with this later, how
Okay,
this sits in statute and what is the
Point.
intent of it in terms of,
I just didn't know if I was missing something you all have.
No.
That's why.
You're not missing it. Go ahead, Jen.
Principle number 7 is that individuals have a personal responsibility to maintain their own health and to use health resources wisely, and all individuals should have a financial stake in the health services they receive. Principle number 8, the healthcare system must recognize the primacy of the relationship between patients and their healthcare practitioners, respecting the professional judgment of healthcare practitioners and the informed decisions of patients. Number 9, Vermont's health delivery system must seek continuous improvement of healthcare quality and safety and of the health of the population and promote healthy lifestyles. The system therefore must be evaluated regularly for improvements in access, quality, and cost containment. Number 10, Vermont's healthcare system must include mechanisms for containing all system costs and eliminating unnecessary expenditures, including by reducing administrative costs and by reducing costs that do not contribute to efficient, high-quality health services or improve health outcomes. Efforts to reduce overall healthcare costs should identify sources of excess cost growth. Number 11, the financing of healthcare in Vermont must be sufficient, fair, predictable, transparent, sustainable, and shared equitably. Number 12, the system must consider the effects of payment reform on individuals and on healthcare professionals and suppliers. It must enable healthcare professionals to provide, on a solvent basis, effective and efficient health services that are in the public interest. Number 12 is that Vermont's healthcare system must operate as a partnership between consumers, employers, healthcare professionals, hospitals, and the state and federal government. And finally, number 14 is that state government must ensure that the healthcare system satisfies the principles expressed in this section. And then I think at the time we'd been looking at some statutory references to the Act 48 principles. So to the extent that this kind of goes to what Representative Lippert wanted to get into, where these come up, the Green Mountain Care Board is directed to execute its duties consistent with the Act 48 principles. The board also has to review and approve the statewide health information technology plan to ensure that the necessary infrastructure is in place to enable the state to achieve the Act 48 principles. And the board's annual report has to identify how the board's work comports with the Act 48 principles. There's also some language about the Act 48 principles in the Green Mountain Care Board payment reform pilots language, expressing legislative intent to achieve those principles. And qualifications for nominees to the Green Mountain Care Board. The nominating committee must assess the candidates using specific criteria, including their commitment to those Act 48 principles. It comes up in the Health Resource Allocation Plan that in developing that document, the HRAP, the Green Mountain Care Board must consider the Act 48 principles. It also comes up in the all-payer model that in order to implement an all-payer model, the Green Mountain Care Board and the Agency of Administration must ensure that the model maintains consistency with the Act 48 principles. And then there was obviously an additional reference to it in the Green Mountain Care implementation statute for the single payer system. So I can take that down if that would be helpful.
There you have it. But so as you're talking about the role of state government in overseeing the having accountability for ensuring that we meet the principles. So most of that responsibility lies with the Green Mountain Care Board.
I think certainly some of it lies with the Green Mountain Care Board and their enabling language, but the specifics in that last principle are really state government. It's not limited to the Green Mountain Care Board, who must ensure that the system satisfies those principles. So I think as you've moved, for example, the Director of Healthcare Reform into the Agency of Administration, there's a role for them to play as well, and others.
And then through any of our waivers analysis, if we're looking at quality metrics, so that, which we're not going to be talking about too much in here, but that falls into VCures or other, whether we don't have another metric that is the state metric at this point.
I guess I'm not clear on
Well, I'm just
where
thinking
you're going
about
with that piece.
assessment of quality. We also have the Department of Health that looks at our health outcomes. So in terms of individuals accepting responsibility, and so the Department of Health looks at the youth risk behavior survey, for example, or the incidence of different types of cancers or cardiovascular disease, which would be an indicator of overall health, and theoretically could be traced to personal responsibility. But we don't have a direct, there's not a direct line to that. It just simply that's the role of the Department of Health in identifying some of that information and data. And there's nothing in here about diversity either. Go ahead.
Right.
here, I think it's been a few years since this was all put together. And when I look at it, we talk about the relationship between professionals and patients. We talk about the system. We do some reference in here to infrastructure. And underlying all of this is the people doing the work. And we're desperate now for primary care doctors. We're desperate for nurses. We're desperate for mental health professionals. And there's no place in this that clearly to me just states that. And we're
Support.
doing across the board scholarships, loan repayments, all
Yeah.
sorts of stuff. But somewhere in there, though, we're in a crisis of medical professionals. And that's not, it's danced around, but not said.
You're right. I mean, it does talk about the relationship of professionals and patients, but it doesn't talk about the state responsibility for ensuring any kind of, well, the HRAP does somewhat of that,
Yeah, we dance around it.
but yeah, you're right.
But in terms of having an adequate and professional healthcare workforce.
Not there.
And.
So there
but
is,
they-
there is
we-
some of it, and go ahead.
But that's not to say we aren't doing some of that loan repayment and scholarships, but doesn't, we dance around it.
We're
as far
doing
as-
a lot,
Yes, we're
but
doing a
it's
lot.
not the result of any principle that's been put in place.
Yep.
Jen, what did you want to add?
Well, there is some of that embedded in number 4, which talks about other aspects of Vermont's healthcare infrastructure, including the educational and research missions of the Academic Medical Center and other post-secondary educational institutions and other things must be supported in such a way that all Vermonters have access to necessary healthcare services. I think it's looking at it specifically in the kind of the access side, but recognizing the role of the post-secondary institutions.
So,
Touches.
yeah, and I'm glad you brought that up, because when I was looking at reading principle number 1, in my head, I said systematic barriers such as cost and healthcare workforce must not, prevent people from seeking care.
Yeah. That's where it belongs. That's right.
Don't.
If I may also just to draw a distinction between principles and goals. When you create a goal, you create something that's measurable. When you create a principle, you sort of foundation of things to be mindful of as we move forward. Principles were designed to sort of, as you build a single payer system, as you move forward, these are the things we need to be mindful of. If we're trying to create something that we want to measure, then we would create goals and put forth ways to measure, kind of how the healthcare model has, here's our goals, and then here's how we're going to measure it. So before we go down the rabbit hole of that, are these measurable? I would just want to distinction.
Well, I'd like to pick up on that, because that's part of what I was wanting to say earlier, because I think because I wasn't on healthcare when Act 48 was
I was.
passed. Some of us were, I was not. I would just say, and there's a difference between when you're in the room, in the committee that's, really wrestling with this, and I have always, and subsequently, in many now number of years, working directly on healthcare, Act 48 gets brought up. Sometimes it gets brought up, frankly,
As a goal.
as a goal. Sometimes it gets brought up as a cudgel. It's like Vermont's not living up to Act 48, and other times it's brought up in other ways. I have interpreted these principles of Act 48 as aspirational. That's the phrase, that's the word I put on it. That they're, and I think, Nolan, I think that's kind of what you're describing. They're principles to guide us as we move toward where we want to be. But I think that, so I just put that there. I think the principles are aspirational, and they're not just for us to, not that we shouldn't measure and think about how we're trying to get there, but they're not to be measured in the same way. I do have another question, and maybe this isn't the right time and place, but it's something I've been wanting to bring up for some time. And that is Act 48 also, it gets quoted as saying that Vermont should provide as a public good publicly financed healthcare coverage for all Vermont residents. Now that's quotes that other people provide. And I think it's also important for us when we talk about Act 48, what is it? It's something's like, well, we want to live up to Act 48. And that's a different part of Act 48. It's not the principles of Act 48. And Jen, I don't know if you can help help us distinguish between, what parts of Act 48 are statutory expectations and which are not.
So just one comment that Act 48 does say that healthcare is a public good. That is a statement in Act 48. And I don't know exactly where it is in the.
So that's actually what I'm looking at right now. So the phrase public good is used 3 times in Act 48 itself. The first is in section 1, which is the intent section. And it starts with saying it is the intent of the General Assembly to create Green Mountain Care, which was the name of the so-called single payer program, to contain costs and to provide as a public good, comprehensive, affordable, high quality, publicly financed healthcare coverage for all Vermonters. And it goes on. So that's the first place where it's the intent to create Green Mountain Care, to contain costs and to provide as a public good this comprehensive health care. The second is in the purpose statement at the beginning of the subchapter in Title 33, Chapter 18, Subchapter 2 on Green Mountain Care. The purpose of Green Mountain Care is to provide as a public good, comprehensive, affordable, high quality, publicly financed healthcare coverage. And the third place it comes up is in the qualification for, it's a little bit different context, qualification for nominees for the Green Mountain Care Board, and that's regard for the public good sort of more generally. So the public good really seems to be, healthcare as a public good here seems to be in the context of creating Green Mountain Care to provide that as a public good.
Questions?
I mean, I'm not arguing that a principle is different than a goal, but principle 9 says the system must be evaluated regularly for preventive access, quality, and cost containment. Principle 2 seems to be our charge. I mean, principle 2 says healthcare costs must be contained in growth and healthcare spending, and Vermont must balance the healthcare needs of the population with the ability to pay for such care. Whether it's a principle or not, if we agree with that, we have to have a way of measuring it. Otherwise, it's irrelevant. So I'm just like, this feels like a kind of mental exercise otherwise, unless we are trying to understand how we want to live up to that principle in our next 4 meetings. And what information we have.
Well, we would have to look, and as you said, we'd have to look at all the information that we have, all the laws that we passed to support each of the, that would support each of the principles. I think what we might want to do, and we'll have to think about this, we might want to consider what do we need further to demonstrate that we are achieving the goals and meeting the spirit of within the principles. So that's a separate, it's a separate question. If we start going through this and suggesting that we establish metrics for each one of the principles, that'll become everything that we are doing here. We'll be lucky if we finish it by December.
Well, right, that statement must be evaluated. I think you're right. There are a lot of pieces where we do have metrics we are evaluating. And that's what we need to kind of refresh our memories, identify from all those existing reports.
But it could be a recommendation that happen more thoroughly going forward. Otherwise, that's what we'll be here. So, Councilman Hall.
It's in the point under auspices of number 9, you could create goals. When I say goals, goals like by X amount of time, X amount of Vermonters will know That's how you, that's the goal.
Well, it's
You
like,
measure-
yeah,
have a- And we'll measure it with, by using this survey or through this data source.
so, but
You
if,
put it as task force.
yeah, and if you look at number nine, already in some ways there are goals for number 9 that are developed through the Department of Health for the reduction of substance use disorder, the reduction of smoking, and the reduction of cardiovascular disease associated with,
We also hear a lot of that.
yeah, they have goals for mental health, behavioral health. So, well, yeah, so we don't, I'm not sure that we can go through and identify all of the goals, but we might suggest that there are goals associated with each of the principles and that those should be maybe further developed.
Task force, maybe firms, maybe recommend goal.
Yeah.
Legislature should do,
Yes,
that are very specific and then sending them full.
and maybe in a more formalized way, because when I think about all of these things, I think, yes, I've worked on a lot of legislation that supported each of those goals, but maybe not systematically.
That's, yeah, it kind of, there's a lot of scattered things that.
A lot of stuff
to be
going on, but
Pulled together more clearly.
Yeah.
Which ones are in support of which
yes,
principles and.
Yeah.
and What's missing.
any other questions for Jen on the principles or comments? Okay. But review this again, I think.
Yeah. Nice try.
I thought we just did all of our work. No. All right. Well, we already, we sort of have what we'll do at our next meeting. Right? 2, 3, and 5, and we have some witnesses identified. But I think primarily we want to, if at all possible, meet with our consultant.
Yeah, I've actually been taking notes of the different things that we brought.
Good. All right. So the question is, we have a total of 5 meetings. This is number 1. And then we have September, October, November, December. So we have 4
Perfect.
months. Huh?
For meetings.
We have 4 meetings in 4 months, and then we have an opportunity to complete our work. So December would be the time where we would have to review our draft recommendations and make them final,
Mhm.
because we won't meet again before January 15th.
Right.
So doing that calculus, we would have our draft recommendations in November, which means that September and October become the heavy lift for us
Mhm.
and part of November.
So we probably don't want to meet again unless we have a consultant. Right.
September. What's the best way to do this? Would you like Charlene to send a doodle poll out?
Rather than sitting here.
Yeah,
trying to-
that's what I was gonna
I'm
say.
not available, yes, I'm available. I think a doodle poll would be really helpful.
And so
Sure.
today's the 19th of August? I lost
Yes,
track.
it is.
Charlie, yes,
Do you want me to send one for the next meeting or 4?
Four.
For
Four.
September, October, and November.
yes, December.
And you want to pick the dates or?
Well, yeah, I was thinking the dates that are not LCAR Thursdays might work. I don't know, the dates that are not justice oversight, the dates that are not,
That are not Green Mountain Care
Child
Board
Protection
nominating
Oversight.
committee.
the dates that are not Green Mountain Care, this other, what is it? Joint Fiscal Committee. So I think-
Start by eliminating those and see what, if there's anything left.
see what's left.
Okay.
Do you want it to help early? Do you want it to be looking for the second half of these months?
Yes,
I think we should be looking for the second half of September because we have a lot of things to do between now and then.
A lot of prep work, hopefully consultant.
I can tell you September 30th and October 1st are not.
Are not good
available.
for you?
Yeah.
Well, those are the Green Mountain
Mountain
Care
Care
Board nominating committee.
Can I
Okay.
go to suggestion? How about
are you on
we
that
never
committee
send
with
Shirley
me?
the days that
Oh,
don't
yeah,
work,
yeah.
she can build around.
That's a great idea. Okay.
Okay, did you hear what Nolan was suggesting, that we each send days that don't work to Charlene
Oh,
and see if there are a day that emerges that, you know.
She could do it.
I don't even know
A
what
doodle
it is.
poll.
Help her set what's in the middle.
Clue what days don't work.
maybe we can-
Yep.
I know.
We'll do that.
That's like.
I think ideally, if we looked at after September 15th.
Yeah.
Let's talk to Charlene. Let's sit down, Charlene.
Oh, yeah. Yeah.
You don't want them to start from 10 to 30. And yeah.
Yes. No, I have a question about the interview process. You know, I feel like it's really common, especially with such a big charge, that they aren't good at all the things. Right? And I'm particularly worried about understanding disparities and trends about where resources might go to tackle disparities. And I know that there's a lot of new, you know, groups led more by BIPOC folks and other people who are really emerging in that space of health equity. And I wonder if if you're going to be considering that they might need to subcontract part of their work, or really not treat that particularly like an afterthought and not have any expertise in that, but build it in.
What I can say is that in our interview process, we're very mindful of disparities in health between the conversations. And I think that, well, we can talk about it.
Are we off YouTube now,
We are not.
Shirley? I think we can be, because we're just talking process.